Okay, we are almost ready to go. Uh-oh. Okay, perfect. So welcome everybody to this webinar on the building blocks for psychosocial care. We are just starting, we're waiting for more people. But in the meantime, while we wait, I would like to remind you a few basic tips to make this webinar more gentle. So please mute your microphones if you're not speaking. I don't think you are able to turn on your camera because this is a webinar format. So you would only be able to see the speakers, Dorica and myself. But please let us know while we wait for more people to join us, let us know where you're connecting from. If you would like to write in the chat your name and where you're connecting from today. For example, I'm Concha Mayo, you all know me, and I'm connecting from sunny Barcelona. Who else do we have in the room? We have Matt from Cologne, Jose Mentens from Belgium. Perfect. Tanya from Sweden. Perfect. Thomas from Vienna. Thank you, Thomas. Sunny Netherlands. Wow, that's a change. Paul, thank you for writing. Dorota from Switzerland. Maria Beckman from the Netherlands, and Ana Verde from Claudi, Portugal. Okay, Anne from Ireland. So we have such a nice variety of people attending this webinar. Thank you all for your participation. We are going to start with Dorica Dan. Dorica is a member of the Eurodis board, but she's also chair of the Romanian Prader-Willi Association and president of the Romanian National Alliance for Rare Diseases. Thank you for accepting our invitation, Dorica. We will continue with an interview that Matt is going to do to Thomas Flechko. Thomas, I'm struggling with your name, sorry. He's a clinical psychologist from the Institute of Psychology of Development and Education in Vienna University. They will discuss about what the building blocks of psychosocial care would look like. Then we will have pretty much time for questions and answers. So you're very welcome to either raise your hands or type your questions in the chat. And we will finalize the session with Dorica with some closing remarks. So having said that, thank you all for being here, and I pass the mic into Matt. Oh, sorry, Dorica.
Sorry, I was waiting for this, but I didn't know.
I'm so sorry.
Okay. So
I was looking at Matt's face and that got confused.
Thank you very much for invitation. It's an honor for me to be here with you. And I would like to welcome all to Eurodis fourth Mental Health and Wellbeing webinar to find out together what are the building blocks for psychosocial care. Our webinar, as Concha already mentioned, will explore the core components of care to address the psychosocial needs of patients living with rare disease using an interview format. Following the interview discussion, you are invited to be actively engaged and bring your perspectives about what good psychosocial care looks like. We know how complex are the needs of patients living with rare disease through their entire journey, and we need to take into consideration their age, the stage of development, the stage of treatment and prognosis, as well as the support system around them, their current social and financial situation. The high level of unmet psychosocial needs and increased vulnerability of rare disease community were acknowledged in the recent UN General Assembly's result, and they call for a UN member states to develop and to implement effective programs to promote mental health and psychosocial support for persons living with rare condition, and to promote policies and programs that enhance the well-being of their families and caregivers. But what does psychosocial care look like, and what are the building blocks for psychosocial care? Let's find out together with Matt Walls-Johnson, Eurordis mental well-being lead and healthcare advisor, and he will introduce us, also his invited person for the interview. Already Concha told us that is Thomas from which is a clinical psychologist at the Institute of Psychology of Development and Education in Vienna University. Matt, the floor is yours.
Thanks, Dorica, and thanks for supporting the mental health initiative which we're doing in Eurordis. We're really lucky to have your guidance and leadership. Thomas, I've got some questions for you. First of all, thank you very much for agreeing to be quizzed by me in public. I think we often have calls where I quiz you in private, but it's can be a different dynamic when it's when we've got other people joining. I've prepared some questions really to try and unpack what psychosocial care looks like. But we've got people joined online, and after we've done some questions and answers, we open up the floor to make sure other people can ask you questions. It might be a follow-on question. But to get us started, I wanted you to clarify something for me, tidy something up once and for all. I always get really confused. You're a clinical psychologist. There's psychologists and there's psychotherapists, and I think there's also Jedi Knights who work in psychology services as well. They managed to get me to do things I wasn't expecting I could do. So maybe you could clarify the difference between what a clinical psychologist is and a psychotherapist and a Jedi Knight.
Well, for the first part, thanks for inviting me. It's really a pleasure and an honor to be there. You're starting with a difficult question. Probably the easy answer is we're all Jedi Knights, but there are some differences. For the most and major difference is that psychiatrists are medical doctors, and the psychologists, psychotherapists, clinical psychologists, they have different legal basis, so mainly different basic knowledge from university, different studies. The main difference between the term psychologist is an umbrella term for all people working in the field of psychology, but the clinical psychologists work with patients, in any health circumstances or in any health condition. So that's the difference between clinical psychologists and psychologists. And the difference between a clinical psychologist and a psychotherapist is the methodology they use. So right. the psychotherapists, they have a specific psychotherapy school. So they use the techniques that are inherent to this specific school and apply this according to their school to the patient. And the clinical psychology is to a certain extent somewhat broader. They use the technique from any therapeutical direction that fits best for each and every child, patient, family, or to whoever they apply these techniques.
Brilliant. Thank you very much. I always get a bit confused with those, so and I always get them wrong. So it's really good to clarify that for me. So thank you very much. Dorica highlighted that we want to delve into the core competencies of what psychosocial care looks like. But maybe you could just give us a brief explanation of the main principles of psychosocial care.
Yeah, so I think the most important aspects of psychosocial care are, let's say, it's a kind of holistic approach. We follow the so-called biopsychosocial model, indicating that a person is not just the biology, but also not just the social surroundings. But we always have to combine these elements. Like, for example, when a patient comes to our clinic, it is important for us what the economic circumstances are, where the child goes to school, or in which environment the family lives, what are the resources and burdens, and things like that. So this holistic approach is one basic principle of psychosocial care. Next to a few others, like we focus on prevention. We like to not just work when a psychological or psychiatric disorder is already there, but we try to, especially in the context of medical health conditions, we try to prevent further, let's say, damage to the soul or to the surroundings. Yeah, and therefore we also focus our interventions not only to the patient itself, but to the broader context, the family, the siblings, the social surroundings. Yeah, and we try to support patients, relatives throughout the whole process of their disease, and the methodology can vary, as I said before, can vary depending on the phase in which a patient currently is, or a person with a rare condition, living in a rare condition, currently is. So there are different supportive measures in this context, and we try to give them orientation. We try to work interdisciplinary on these aspects.
So really that principle is looking at the individual and their family at their point in time, their point of age development, their point of treatment or journey through their condition. So in a way that you put that, bring everyone into that moment to understand those needs at that point in time, as opposed to a more, I mean, it's great that we have that dimension that in the healthcare system, because I think it's easily forgotten. You know, I know that the evidence base, when I've looked at psychosocial care, and you very kindly pointed me in the right direction, is in pediatric oncology. It's, you know, in oncology and pediatric oncology especially, psychosocial care is really an integral part of that care journey. If maybe you could just give us your view of what the unique aspects of psychosocial care are for people living with a rare disease specifically. Is there differences in the approach or needs?
Well, I think there is a large area where well, pediatric oncology and different rare diseases have an overlap in many areas. But as you said, there are some differences, and I think we have these differences especially in two areas that are inherent to rare diseases. So the first thing is that psychosocial care starts when, in pediatric oncology, psychosocial care starts with the diagnosis. But when I work with people with different rare diseases, and I'm mainly into neurofibromatosis, and I very often hear that the burdens are quite high before the diagnosis is there. And that's a very challenging part for psychosocial interventions, because you don't have the specialists for the disease already as a team. But it's quite a difficulty we have a kind of diagnostic odyssey until it comes there, and psychosocial intervention should start much earlier. And I think that's a big or an important aspect, but still nevertheless challenging. And I think the second part is that there are so many different rare conditions, so many different systems that are involved, so many different organ systems, like let's put it that way, that are involved, that you need so many different specialists. And the psychosocial teams, from my experience in every clinic, they are so if there are specific psychosocial teams, they are mainly part of a specific, let's say, group of diseases. Yeah, but in many hospitals, you don't have psychosocial teams for rare diseases, because the rare diseases are not a single ward. So I think that's the point. And these are the main differences, I think, between the psychosocial care in oncology and in rare diseases.
So in a way, that understanding the specific needs of a condition or a group of conditions is fundamental to being able to provide tailored support to understand the context which an individual is going through at that point in their natural history of the condition. So that's really, and in pediatric oncology, it's probably more focused as an approach. So, okay. I'm just trying to think. So if you, with the delivery of psychosocial care, you talk about that connection with the medical team, the wider medical team. What's the best practice structures for involving that psychosocial team within the main healthcare journey?
Well, I think well, the first part is the regarding the timeline. Of course, as early as possible. Yeah. When I look at the experiences we made here at the Medical University of Vienna, we have in different wards, we have different models, and I think there is especially the so-called integrated care model, which we follow in the Children's Hospital. This means that the psychosocial team members are an integral part of the whole ward, of the whole staff of the ward. So they are, as opposed to the consultation model, where psychosocial team members are well, consulted upon request. Like if there is a I put that into well, with a question mark at the end. So difficult patients or difficult situations. So whenever healthcare or let's say medical doctors, for example, face a difficult situation, they consult a psychosocial team member. But that's not the point. I think it should be the other way around. There should always be a psychosocial team member at hand. And we have even in our outpatient clinic, we always have different professions, like the medical doctors, the psychosocial team members, and also the nurses. And they are there together for the patients to direct their questions to different professionalists. And I think that's at least here in Vienna, but I know that from many other children's hospitals, I think that's a very good approach to implement psychosocial care in a way that patients really profit from.
And being an integral part of the team then, because you're not there at all time or contact. The family or an individual comes into contact with the specialist nurses or physiotherapists. It's a wider team that they engage with, and so by you being part of that multidisciplinary team, you can almost level up, skill up that wider professional medical professionals to be able to be a bit more psychologically informed. Is that the approach which you take in
Yes,
Vienna?
yes, definitely. So we can the first thing is we can set interventions very, very early, so we can see when there is any difficulty, any burden that we need to address, and we can tell the other professionals, please look at this or that. Yeah. And we can tell them, okay, be sensitive in this respect, or when the patient comes next time, please address these questions. Yeah, so to form a kind of yeah, psychologically informed approach. Let's put it that way.
Because I that model of that preventative approach is really key, isn't it? If it was that consultation model where when the nurses or physicians think, oh, you probably now need to go and see a psychologist for support, that's probably too late.
Yeah.
So by you being integrated in the team, you're able to get that early awareness within the wider team, and that can circumnavigate or stop things becoming challenges for the family.
Yes, definitely, and also from an economic perspective. So if we focus on prevention, that's much, let's put it, cheaper than curing a depression or a post-traumatic stress disorder. Yeah,
And better quality of life for the people
definitely.
affected.
Definitely.
So you talk about the psychosocial care and it focusing on the family as well as the individual. Can you explain sort of, is there a difference in your approach then to maybe a young child with NF1, how you interact with the individual, the child versus the interaction? Are they different set of needs? How do you approach the two groups?
Well, of course, there are different settings, but it mainly depends on the individual situation. It mainly depends on the individual needs. So for some children, we need specific I don't know, techniques, specific ways of communication. But actually, in all families, in all patients and their families, the approach should be twofold, like the patients and the environment. I can't actually think of any case where we just focused on one of them. So I think this always has to go together. And while we support the children in like prepare them for different medical procedures, we also prepare the parents how they can support their child. What can they say? What can they do? Where should they stand? What words or what phrases could be helpful? But also very, very practical issues like what to do with the siblings while the patient has to undergo a certain procedure, or who is going to cook the meal when the mother or the father has to go to work, or the other one has to stay at hospital. So very, very practical questions we try to address, and yeah, things like that. So I think there are different approaches. In both cases, we try to further the resilience of the patient and of the family system.
So you know, in maybe we can sort of step into your clinic environment in the medical university hospital in Vienna, and you talk about building and strengthening resilience and the resources of the family. Can you give some examples what that actually means? You know, whether it's around coping strategies or other things?
Yes. So to give some clear examples. So, for example, when a new family comes into our clinic, the first contact is, for example, with a social worker, asking for questions like, where are you going to stay, or where is the family going to stay whilst the patient is here with us in the hospital? Who is going to stay with the patient? Who is caring for the siblings? So that's part of the social worker. They're also addressing, so if a diagnosis is already made, they're addressing any financial issues, any further social issues that may arise from this situation, what to tell the employer, for example, how long will this take, things like that. For the patients, we have for example, I'm just highlighting a few things. We have many of our patients have to undergo regular MRI scans. And of course, when the children are young, this anesthesia is quite a burden for them. So we try to prepare our patients to manage MRI without anesthesia. And we have a specific psychosocial education program and we have quite good rates of children already from the age of 4 years managing MRI without anesthesia, who underwent our preparation programs. It's a gamification approach, actually. So the children are playing games. They're practicing relaxation techniques. They're practicing to lay still. And we also have one very important aspect for any psychosocial intervention is always information, or as we call it, psychoeducation. So we try to give information about the specific upcoming procedure. And I think we, as adults, we know that very well. We like to know what is going to happen. And if we exactly know what is going to happen, then it's in many cases, not in all cases, but in many cases, less frightening. And I think that's one core aspect of psychosocial interventions. Also supporting patients, like taking their medication. This can be an important issue. So for some children, the pills are not very tasty, or different procedures are not very nice, and we try to help them. And this also, of course, when I said, well, okay, we support the patients, we support the families, but this also supports the whole procedure, the whole healthcare procedure, and of course also outcome.
I hadn't thought about it like that, actually. By giving that, we did a publication for our diagnostic survey, and we found that people who got psychosocial support through the diagnostic journey got a diagnosis quicker by over a year. So what you're saying is actually within the healthcare system, getting treatment and by having psychosocial support through that journey as well, people are more adherent to following the treatments which are given. I hadn't thought about it in that way, that actually, and we know that by following evidence-based guidelines, people have better outcomes ultimately. So that's a real facet I hadn't considered before. But maybe you know, that the lovely pediatric oncology guideline in Germany on psychosocial care, there was a massive section on interventions. I sort of didn't manage to get through, if I'm honest. Maybe just you could give some examples of the supporting therapy. What are the types of supporting therapy, whether it's play therapy or stuff like that? Maybe you could expand that a bit.
So well, it's difficult, as you said, to focus on a few sentences in this such wide area of different supportive measures. They have in common that they focus on the current health problem or the current health situation and finding out the resources. So this can be like giving patients orientation at the beginning. Yeah, so when during these diagnostic procedures, it may be of help to I don't know, to walk with a child through the ward and take a picture of every important person the child is confronted with and put the names on the pictures to get information with to which people they are talking to, who are the people they can address their questions to. So this could be a first intervention step. Then whenever fears or anxieties arise, we may work with relaxation techniques. There are different forms of relaxation techniques. So whenever it's difficult to express emotions, feelings in this complex situation, then like music therapy or art therapy may be interventions that may help to express what thoughts are in the heads of the children or what feelings are there inside. In many cases, we act as mediators between the patient, the family, and the healthcare providers. Like, for example, a diagnostic or a discussion where the patients or the parents talk to the healthcare professionals about the planned therapy for planned forms of therapy. There is so much information, and from a neuropsychological perspective, we know that immediately afterwards, after such a conversation, 80% of the information are forgotten. So we need to address this issue, because otherwise the patients remain uninformed and the healthcare providers will say, well, we talked about that already. So we need to act as mediators, because such situations can lead to many misunderstandings, like, for example. Just to give you a few examples, of course, if there is already a specific psychological disorder or a very concrete burden, we also work with during the aftercare, for example, we focus on trauma therapeutic interventions and in my area, I also very much focus on school interventions. Many patients have different, or the health condition has a distinct impact on either cognitive functioning or also social functioning, and we need to address that in the context of school re-entry after, for example, a form of absence or a phase of absence due to the condition. And we need to prepare teachers, we need to prepare classmates, we need to address the situation. Like, I mean, in pediatric oncology, we often have the situation that patients are absent from school for 1 year or even more, and we have to find a solution for this situation, because yeah, otherwise it can be quite challenging afterwards.
Is that sense of being out of school and being out of a community, that also has an impact on quality of life of an individual, feeling isolated, alone, lack of peer support. I like that the idea that, you know, trauma therapeutic intervention around it being maybe a traumatic process, and trying to make people feel more comfortable around that, whether that's orientation. I worked with a service and they did mindfulness, and you know, at the time I thought this is quite woolly, you know, fluffy, but actually for someone who's quite anxious or hyper alert due to the situation or scared, actually that is a really effective technique. So it's really interesting. And I think you painted a really good picture of how things can play out in your clinic, as it were. But maybe if we take a step back, and I'm just wondering, is this, you know, what you have sounds like a gold standard. It sounds like if we all could have a service like yours for the rare diseases we represent, we would jump at the opportunity. But do you have any insights on how we could make psychosocial care part of mainstream medical care?
Yeah, I think the one thing I already mentioned is that we actually need psychosocial members as integral part of the staff. So I think with bringing the psychosocial way of thinking into the field, we would already have a much better focused approach in all these areas, and we could really work on prevention. So, and even if we have the guidelines, we're still struggling, of course, with financial issues. So I think it's important to document what psychosocial interventions can do, and we would probably also need to focus on what this scientifically it's quite a difficult question to address, but what would happen or what happens if we cannot do what we want to do. Yeah, and well, that's actually a situation we quite often face, because we don't have the resources. And to address this in a scientific study, for example, what will happen if the patient does not get the intervention at the time he or she needs to? I think this is very crucial. That's the one part, and the other part, of course, is information. Like we talked about the psychologically informed stuff. So we recently published a precautionary checklist for especially for any healthcare providers working with neurofibromatosis. So a precautionary checklist, so everybody who has a patient with NF knows what is to do at which time point. And I think things like that may help to implement, and psychosocial issues are addressed in this precautionary checklist. And I think when we manage to level up the awareness for psychosocial issues in any health situation, I think this would already be a good point, a good start.
Brilliant. Thank you, Thomas. So I'm going to do the last question and then open up to the floor. I know the chat's been active, so Concha, maybe you could see whether there's any questions from people in the chat, and we could ask them to unmute their mic and ask them. But the last question, just to end on something fun, really. And I made a joke earlier about psychologists being the Jedi Knights of the healthcare system. But if you really did have a superpower, what would it be?
Well, it would be definitely something on the light side of the force. Well, we psychologists often face well, actually, it's a prejudice that we are able to X-ray people just by looking at them. So we can't, but that would be a good.
You can't?
No.
Oh, okay.
But that would be actually a quite good power, because it would make things easier to a certain extent, and I would especially use this power to work with the legal representatives and to understand their arguments for not adopting a specific strategy, or for not authorizing a specific aids or things like that. So that would really be helpful.
So to shed light on the regulators' decision-making processes, that's brilliant. Thank you very much, Thomas. I'm going to see whether there's any questions from the floor. I can see the chat's been active. If anyone wants to unmute their mic. Don't know, Concha, how to do this.
Well, if anyone would like to talk or to raise any question, you could ask. You could raise your hand, so I can give you. I can open your mic. If not, we can start in the meantime with a couple of questions that I can see here in the chat. There has been a lot of.
We've got
Okay.
So.
Okay, your mic should be. Okay, perfect.
Okay,
hi, Anne.
Yeah. Hi, Matt. Lovely to be here. I put it in the chat there. It's very difficult to listen to Thomas as a mother and to hear all of those things that we so want and need and not to have them. And I have often said, because I'm the chairperson of 22q11 Ireland, so our children have 22q deletion syndrome. So they are already genetically predisposed to mental health issues, from anxiety right up to psychosis. And there is no cure or treatment for 22q at the moment. But my argument has always been, I now have an adult, she's 40. So my argument has always been that a care pathway is a treatment. When there is no cure, a care pathway is a treatment. And we have been lucky enough to, we worked very hard to get a care coordinator who has decreased the burden of stress, particularly the maternal burden of stress. But what my point that I want to make really is that I feel that there's too much emphasis on clinical aspects of rare disease, which is important. I understand that, but there's not enough emphasis put on the psychosocial needs, which to my mind, and having had my lived experience, are equally as important, if not more, because a lot of the time, the physical issues, the clinical issues, they can all be fixed to a certain degree. Like you can have surgery for certain things, but the other stuff is psychosocial, and it affects the whole family. And we're very often left just to fend for ourselves in this respect, Matt. So yeah. I'd like to know if your Ordis could shine a more focused light on the need for psychologists, and maybe a conference for rare diseases, and bring all the psychologists to it. A psychology conference, maybe. We don't have psychology. Our care coordinator is doing so much work in this area, even though he's not a psychologist. And it's like Thomas said, I listen to Thomas and I hear that he has challenges also, but financially, and no recognition here. So it's been really hard. But I think, I've never met a family yet anywhere in any country who doesn't talk like I do. So I think if we had the numbers, if we had some collective research done, if we had something that we could say to the European, to get it out to our respective countries, this is what we need. We spend so much time on other things when this is really important. Sorry for the long-winded.
No, it's fine. I think we are trying to, I mean, your Ordis has highlighted mental health as a priority for our community. I think that's taken too long for us to get to that place. And as you say, Anne, whenever I meet anyone from the rare disease community, I haven't heard one person who says this isn't a massive issue for them, but we prioritize those other things like diagnoses, research for treatments, etc. And we're really trying to put this centre stage now. We had a session at ECRD last week on mental health and rare diseases, and we're part of this webinar with Thomas. We're drafting a position paper saying what does psychosocial care look like, and that we can get member states to implement what the UN General Assembly has asked that they do, was to develop psychosocial care for people with a rare condition. So we're trying to make that a reality, trying to make that very visible in a concrete way. Last week at ECRD, we had Anne-Sophie Laplante, I can't say her name very well. She's a member state lead in France, and she came to the mental health session which we had, and she said, this is really interesting. I need to know more about what psychosocial care for people with a rare disease looks like. Can you give us a document which explains that, so as she can put that in place in France? So I think that we're trying to make those steps to make it visible. And that's why we had this webinar today, because I'm a native speaker and psychosocial care, it just doesn't mean anything to me. So that's why we wanted to try and shed some light on it with Thomas. But maybe Thomas, Anne was highlighting about, the challenges to get these types of services like yours in place. Maybe you could explain, how did you achieve that in Austria? Because I believe it wasn't through the government.
No, it was not. I mean, part of it was because the patients in I think in many countries, but in Austria, have the right of psychological services when they are in hospital. So that's still one major part. But the right for psychosocial services and the extent of the needed psychosocial services are two different aspects. I think what we focused on from the very beginning was this, what I mentioned at the beginning of our interview, this biopsychosocial approach. I think it's really important not to think of, as you said, clinical issues and psychosocial issues, or medical issues and psychosocial issues, but it's biopsychosocial. So the psychological issues are not somewhere outside our body. So they are part of us. They're part of our feelings, of our thinking, and the psychological issues and also the social issues influence how our body works, and how our body works influences our psychosocial well-being. So I think we need to put that together, and I think that's a very, very crucial thing, to get this into the mind of each and every healthcare provider, to have this holistic approach. And I think that's a very short answer and not very precise or concrete when it comes to specific actions. But I think that the way of thinking influences also the health policies.
Thank you. I'm just looking at some of the other questions in the chat. There's a question from Naila. She was wanting to ask, in your clinic, do you work with genetic counsellors, and how do they facilitate support psychosocial care, and in instances where genetic counsellors GC appointments was very overwhelmed by patients, how long after do you refer or try to get an appointment with a psychologist or a social worker? So do you work with geneticists, genetic counsellors?
Yes, we do. I'm not really the specialist, I fear, to answer this question. We work with genetic counselors. We have in the pediatric ward, we often have these issues. Well, I'm not really the right person to answer this question, but I think in this case especially, it's important again to prepare families, to support families, to support in their individual way of decision making. And you as a healthcare provider, you cannot assume that the patients will manage on their own, because it's such an outstanding situation that guidance accompanying them through the process, things like that are really important. How long after do we refer? I can't really answer that in general. In the genetic area I work in neurofibromatosis, we do that upon the needs of the patients or the families. But I know there are other facilities, other services that have other ideas dealing with that.
Brilliant. Concha, is there any other questions from the chat?
Yeah, just a second.
So Anne's saying, Thomas, that we should get you to be a keynote speaker at one of the Eurodis's conferences. So I'm going to mark your dance card for the future, maybe for our membership meeting next year in Latvia.
Great.
There is a question from Paul Gicht. Would it be helpful in our network if our network prepares formats for psychological care before diagnosis? And there's a second one. Is a problem of lack of psychologists in integrated care specific for rare diseases or for chronic diseases in general?
Paul, if you can unmute your mic, your question, which was asking about the prepare formats of psychosocial care before diagnosis, maybe you could expand on that a bit. Are you there?
Let me help him. Okay, I think you can do it now, Paul.
Yes, thank you. You were asking, Matt?
Your question was that would it be helpful if our network prepares formats on? I just wanted you to expand on it a bit because I didn't quite understand it.
Well, I could imagine that we make a kind of booklet or something that shows in various settings best practices, how psychosocial care in rare disease care is quite helpful. As I said, to inspire those who haven't that kind of care. And sometimes it's also a matter of having the ideas, convincing others, legal people, managers, etc.
If I may answer, Paul, thank you for this very important and interesting questions. I immediately have an association to something we did actually. I shortly commented on the school re-entry issues of after a specific therapy, like for example. So we in fact did a kind of booklet, a kind of brochure dealing with the so-called disadvantage compensation. I'm not familiar with the disadvantage compensation in all the different countries, but I'm quite well know the situation in Germany, Austria, and Switzerland. And for example, in Austria, we had the difficulty that there was no legal basis, or at least the education system, the education system didn't know about the legal possibilities of teachers supporting children with any chronic condition or also rare condition. And we did this booklet, and it was quite a sort of handbook. And in every conversation with the teachers, we used this handbook and said, well, that's the legal basis. That's the way of dealing with the child. That's the way of teaching the child in a way that the health-related disadvantages are no longer a problem. For example, if due to a specific condition, the patient is somewhat to some extent slowed down in the pace of thought, the pace of thinking, or information processing speed, then the child, of course, needs more time at school. And this is independent from any educational plans. So that's just within the regular school. And by using this booklet and by constantly talking about this disadvantage compensation, we managed that all or many of the legal authorities of the educational system in Austria now know what this disadvantage compensation is, and especially the families ask for that. So it's twofold. It's on the one hand informing the people working in this field, but on the other hand, it's also building up knowledge on the side of the families and on the side of the patients, and to ask for the help they need, and to know the rights they have in this context. So yes, some parts are true for chronic diseases in general, regarding your second question, but I think for many rare diseases, these strategies can be adopted, and we don't need specific procedures.
And that kind of such a best practice. Let's bring all best practices that we have in our network together and start from that, inspire each other and inspire others.
Mm-hmm. Yes, definitely.
So I last week at ECRD we launched our co-creation process for a toolkit for our community to draw on what works for others. So we'll definitely look at Thomas's booklet and other types of tools and approaches out there to inspire and to see whether these can be scaled up for others. Maybe it's the last question because of time. Concha, we've got Sophie.
Yeah.
Hi, Sophie. Nice to see you, hear you again.
Hi. Thank you so much, Thomas. Thank you, Matt. Thank you, Concha. It's such a great webinar. I just had a question further around, Thomas, what you mentioned about we need to have the data to show, how the lack of intervention in the psychosocial field affects to show the policymakers or the decision makers. I am working on some scientific research at the moment for the condition that I represent in this field, the psychological effects, for the exact same purpose. Are you or Eurydice, are we focusing on doing this? Are we focusing on doing some research in getting that data? Because I potentially have people in my network who would be interested in conducting this study, psychologists and so forth, who would technically be interested in leading a study like this. Have we started it? Is there data available? Is there other people that are interested? It's good. Would be good to know where it's at with that.
We started a literature review looking at the psychological support post-diagnosis through living with a rare condition, and we've got about, I think, over 150 publications which have got to the shortlist, which we're reviewing. So we definitely be pulling from that any data around needs, and I can, because that we're just at that stage after the search and screening stage, we can definitely make sure that we can identify if there's any impact data where this wasn't in place. But in terms of conducting fresh research in that way, we're not looking at that at the moment. I don't know, Thomas, is there any, do you know of anyone doing research in that area of where there's a lack of, to show the lack of the impact of not having these types of support?
So we in our department, our clinical social worker is analyzing different pathways of social interventions and looking at how different social interventions and burdens at different stages of the diseases, what impact they have on the long-term outcome. So that's Kerstin Gottendorfer in our department. So I can make contact if this is interesting. And I haven't spoken to my colleague, having come back from the PsyOp Europe conference last week, and I think there was a presentation on this, especially on this issue, but with a focus on pediatric oncology. I will try to interview her what the results were. But yes, definitely a European study would be great. And well, yes, thank you. You already wrote it in the chat. Let's connect.
Mhm.
I think we should move on to Dorica for the closing remarks. So Thomas, thank you very much for enlightening us on some of the building blocks for psychosocial care. I definitely am walking away knowing more, and I'm going to consolidate the feedback you've given today. And we've got a couple of workshops with some patient representatives in the coming week to develop that further, to really say from a 360-degree perspective what this looks like for people with a rare condition. So thank you very much for your time. I know you're very busy with your clinical duties, but really appreciate you shedding light on that.
Thank you so much. It was really a pleasure and an honor. Thank you.
Thank you, Thomas. Dorica, would you like to do some closing remarks, please?
Yes. Thank you very much, Thomas, for this interview, and Matt for this interview. It was very nice to hear you. As you could see, all the parents. Sorry, my video didn't start. So all the parents are very interested in this topic, and I'm very interested too in this topic. So our journey today have started with the differences between the psychologists and psychiatrists' role and clinical psychologists. Then we discuss about the psychosocial model and holistic approach, recognizing and to address the impact and the effects of rare disease on the mental status and emotional well-being of patients, their family members, and their professional caregivers. Then we talked about that it is focus on prevention, intervention to the broader context, patient, family members throughout all the process to give the orientation and working interdisciplinary. This is very important. Families may benefit from counseling, education, and connecting with others who have the similar experiences. Then Thomas told us the unique approach of psychosocial for care for rare disease start even before the diagnostic. And it is very challenging for the patient and for the family. And there are so many different rare conditions, and we need so many different specialists. Psychosocial teams are mainly the group of for group of diseases and not for specific diseases, like in pediatric cancers. And we need to understand the needs of a disease or a group of disease. This is essential in offering a holistic approach. Then he shared their best practices from their clinic in working with neurofibromatosis patients, not only with patients, but with the entire family, including siblings, to improve their resilience, both for the patients and for the families. He reminded us that each rare disease presents unique challenges, so personalized care plans are essential, including psychosocial education. He mentioned some games that are used for to make children feel children. This is very important. We use this in NeuroCenter too, and I really like this approach because they need to be children, even if they need a lot of care. Accessible resources, empathy, and a multidisciplinary approach contribute to effective psychosocial care for rare disease. Thomas also mentioned about his experience in working with schools, teaching teachers more inclusive methods for children that experience absence in schools, and talking about how to mainstream the psychosocial services. We need to document what psychosocial intervention can do and focus on what would happen if we don't intervene. This is the systemic approach in any system, and I think this is very correct. Also, information is very important, and resources for any healthcare provider, a sort of checklist that each healthcare provider should have. It was mentioned that disadvantage compensation as an example that was not known in the community, and this is a kind of information that is very useful for the patient and for the family because it gives rights. It comes with the rights of the patients. And last but not least, the insights gained from this webinar will be used to inform and develop a Furordis position paper on mental health. This is my conclusion. And thank you very much for your attention and for inviting me today, because it was a very, very interesting debate.
Thanks,
Thank you,
Dorica.
Dorica.
I think Dorica, that was such a great wrap up. We definitely should get you to more Eurodis events, because I couldn't have done that so succinctly as you have. So thank you very much, Dorica. Concha, do you want to close?
Yeah, well, thank you everybody for joining us today. Sorry that we went further the time we expected. We will be sharing the recording with those that have been finished earlier, and see you very soon.
Concha, just say about the survey.
Oh, yes. We are going to share with you a survey. Let me show the slide with it. This is a satisfaction survey for the webinar that we will invite you to join either now or after the webinar. Okay. Thank you.
Thank you.
Thank you. Bye.